dilemma doesn't end. No one knows the end of this pandemic. Varied treatment options and biomarkers are in business, but we are yet to find the right one. I, Dr. Bharat Jagyasi, have with me Professor Jean-Louis Vincent. Professor Jean-Louis Vincent is Professor of Intensive Care Medicine at the University of Brussels, Belgium. He is Editor-in-Chief of Critical Care, Current Opinion in Critical Care and ICU Management and Practice. He is past President of the World Federation of Societies of Intensive and Critical Care Medicine and past President of European Society of Intensive Care Medicine. Professor Vincent, welcome to podcast ISCCM.
Hello to everybody. I am with you in these difficult times. I hope it will get better soon.
So there's another test around the corner, DDimer. So just wanted to understand, is DDimer a marker of inflammation or a marker of thrombosis? And do we have to follow it up with treatment with steroids or treatment with anticoagulants? What exactly is the pathophysiology behind this going up?
Yeah, well, it's actually both. We know that COVID-19 is primarily an endotheliopathy. The endothelium is the target organ of the virus. So it could be in the lungs with lung edema, it could be anywhere in the body with multiple organ failure, and we show that autopsy, that endotheliopathy, is indeed found in virtually every organ. So when there is endotheliopathy, there is a coexistence of inflammation and coagulopathy. So the D-dimer, of course, the D-dimer levels, of course, come primarily from the coagulopathy, from the increased coagulation, activated coagulation. But the activated coagulation is really intertwined with the inflammatory response. So you could consider that to some extent, the D-dimer levels are related to the severity of the inflammatory response. But as I said, there are other markers of the inflammatory response, including CRP or ferritin, for instance. So can we use it to as a prognostic marker? Yes, indeed. It's clearly a prognostic indicator. Should we follow it over time? Yeah, because it reflects the general evolution of the disease. If it goes down, it's a good sign, definitely. Now, could we use it to titrate our anticoagulant therapy? Maybe to some extent. It's true that the high D-dimer levels would encourage you to push a little bit more the anticoagulation, but we know that anticoagulation should not be excessive either in critically ill patients. There is a risk of bleeding, and the benefit seems to be relatively limited in critically ill patients. So prophylactic heparin administration for sure, but therapeutic heparin administration probably only in cases associated with very high D-dimer levels, and in particular those with documented thromboembolic phenomena. I would not use D-dimer levels to decide whether we should give steroids or tocilizumab, because that is not a clear positioning of D-dimer levels.
So when you said very high level of D-dimer level, so high is what? It's twice the normal limit or 5 times the normal limit? What is your practice? I know there's no data to this, but what exactly is your take on it?
No, it would be, I would say, more than 5 times your normal limit, because we have some patients with really very high D-dimer levels.
Okay. Now the most important one, sir. I mean, I know the steroids were the one which were put on, the first drug to reduce the mortality. And I believe as of now is the only drug which has been known to reduce the mortality. So, sir, when do we start the steroids? I mean, is the exact timing, as the remap cap showed, they use it in the patient who are on the oxygen. So what's your take on it? When do we start it?
Well, I think we can only refer to the experience from primarily our English colleagues. And that is that we should reserve it to the rather severe cases. When I say rather severe cases, The patients may not need to be in the ICU. The patients do not need to be on mechanical ventilation. And as you indicate, it may potentially be given a bit earlier in patients who develop substantial hypoxemia. So optimally, we should reserve corticosteroids to those who need oxygen. Now, I know that in some places there is a lack of oxygen, and we may actually try to avoid giving oxygen to patients who still tolerate their hypoxemia. So if there is profound hypoxemia, then indeed I would go ahead and administer the dexamethasone 6 milligrams per day to those patients who are in the hospital with severe hypoxemia. Could we use methylprednisolone rather than dexamethasone? Well, you could argue that the study has been done with dexamethasone, so you should stick to it. But on the other hand, there is no reason to believe that there is anything special associated with dexamethasone instead of methylprednisolone. So a number of people around the globe give 32 milligrams per day of methylprednisolone, and I think it's okay too. So 6 milligrams per day of dexamethasone, Decadron, or 32 milligrams per day of methylprednisolone, which is Solumidol.
I have two more questions for you on this. When I was talking of early steroids, obviously not in the early in terms of the number of days of the disease. As we know, initial phase is more harm. In the later phase of disease, not someone who is really hypoxic, but if we do a 6-minute walk test, SpO2 goes down, or if initial readings were supposedly 97, 98, now it's 92. So it indicates there's a sufficient damage which is happening, but exactly not a hypoxemia. So should we be considered steroids in those kind of situations as well?
Well, I think it would be hazardous to extend the indications because we have no evidence that it protects in milder cases of hypoxemia. We should not forget that corticosteroids, of course, have their side effects. And in particular, they may reduce the patient's immunity. And we know in COVID that some of these patients develop very bad secondary infections, like in all viral diseases, it's a threat. And so let's be careful. We should not extend the indications beyond what is known. And what is known is that it could protect patients having severe hypoxemia.
So any role of high-dose steroids? I know you're going to put it, there's no study, it's not been studied, so we shouldn't be using it. But since we've been using immunomodulator like tocilizumab and all, so can we be using higher dose of steroids also in certain cases?
No, I don't think we should. No, because there is also some evidence in the literature that high dose of corticosteroids may harm. So again, these are very effective substances with many effects, and so we should be careful and we should not exaggerate with the use of corticosteroids. I would stick to the current indications, not more.
Thanks, Professor Vincent. Thanks for joining me. It was lovely talking to you. Truly appreciate it.
It's a pleasure. My best wishes to you and all my Indian colleagues.
Thanks a lot.
I hope it will get better soon.
Thank you very much for doing this.
Thank you.